Hello, everybody. My name is Barak Kassar, and I'm very happy that you are all here from all parts of the world. It's very exciting to have you. I'm going to quickly introduce our moderator, Dr. Pierre Goban, and then our speaker, Dr. Matthew Amans. Dr. Goban is an internationally recognized expert in the field of interventional neuroradiology. Also international, as you'll find out. He's got decades of experience in the treatment of vascular diseases of the brain, head and neck, and spine. He's a pioneer in endovascular treatment of cerebral aneurysms and has also developed and established minimally invasive surgical approaches to treat acute strokes. Dr. Goban completed his medical degree internship in radiology residency at the University of Paris in 1988, trained in interventional neuroradiology there and performed the first GDC coil embolization in France for the patient with cerebral aneurysm. In recent years, Dr. Goban has conceived the concentric retriever, an endovascular device for cerebral embolectomy to treat acute stroke. He's also the endovascular member of the team that developed intra-arterial tumor therapy for the treatment of retinoblastoma. And I want to say I had the honor of witnessing this on a video screen, Dr. Goban performing such a thing, and it's quite a miracle. Since 2001, Dr. Goban is professor of radiology in surgery and neurology at the Weill Cornell Medical College and director of interventional neuroradiology at the New York Presbyterian Hospital, Weill Cornell Medical Center. Dr. Goban is the author of more than 100 articles and reviews pertaining to interventional neuroradiology. Dr. Goban will be moderating, and our speaker, we are very honored to have Dr. Matthew Amans, neurointerventional radiologist at the University of California in San Francisco, UCSF. My hometown, where both my children were born at UCSF. His focus is on treating dural, arteriovenous fistulas, acute stroke, cerebral aneurysms, and idiopathic intracranial hypertension, or IIH, which is, of course, why we are all here today. Dr. Amans founded the UCSF Pulsatile Tinnitus Clinic and serves as co-director of the clinic. The clinic's team of doctors and researchers has achieved great success in identifying and curing the underlying causes of pulsatile tinnitus. Dr. Amans also leads a UCSF laboratory dedicated to pulsatile tinnitus. His research team has developed new non-invasive methods of evaluating blood flow abnormalities in the brain's vessels, including a way to visualize flow in the cerebral vein. In addition to diagnostic techniques, the lab has developed novel therapies for vascular diseases using technologies that disrupt flow. Dr. Amans is a senior member of the Society of Neurointerventional Surgery and a senior member of the American Society of Neuroradiology. He has leadership roles in numerous professional organizations, including the American Society of Neuroradiology, American College of Radiology, International Society of Magnetic Resonance in Medicine, and American Heart Association. He is also a reviewer for various medical journals serving the fields of radiology, neurosurgery, and neurology. Thank you both, Drs. Goban and Amans, and thank you all for being here. We hope you find it to be a very useful session. Thanks.
Thanks, Barak. Should I just fire away here, Pierre?
Absolutely, yes.
Perfect. All right. Well, thank you very much. I appreciate the opportunity to be here today. And I'll be presenting the work on behalf of our team, really, at UCSF, which is the UCSF Pulsatile Tinnitus Clinic that, as Barak mentioned, I started quite some time ago. And we've had the fortunate pleasure of seeing thousands and thousands of patients with pulsatile tinnitus and really learning a lot about this disorder. Throughout the talk, you'll see various QR codes that are going to be links to the different manuscripts if you're interested in reading them. Otherwise, sit back, relax. Feel free to ask questions in the chat that Dr. Goban will be moderating. Most of them will probably be answered at the end or maybe as we go along, but happy to chat. All right, so this is some of the research. I thought I'd start with a pretty picture. This is a patient who has a dural arteriovenous fistula, which is one of my near and dear favorite things to diagnose and treat as an interventional neuroradiologist, which is an abnormal connection between the high blood pressure arteries and what should be low blood pressure veins around the brain. And this is the cause of this patient's pulsatile tinnitus. And what we're looking at here is a combination of two sequences, and this is research out of our lab. The first is a contrast-enhanced MRA that's timed to the venous phase, and what we see in gray are the big veins that drain the brain. And the colorful lines are a research sequence called 4D flow MRI. that allows us to look at blood flow and trace blood flow, including its velocity, speed, and path over time. And if we take a closer look, what we're seeing is really high velocity blood flow coming in from these different arteries, the middle meningeal and occipital arteries, and they connect into a parallel channel that's formed within this patient's dural venous sinus. This abnormal connection is what's causing this patient's pulsatile tinnitus. And this is one of the more potentially dangerous causes of pulsatile tinnitus. All right, now that I spent 2 minutes on pretty pictures, I thought I'd just go right to the key take-home points of my slides today. And number one is that pulsatile tinnitus is serious. And the second key point is that the most common cause of pulsatile tinnitus is actually venous sinus stenosis, and many of the underlying causes of pulsatile tinnitus are able to be treated well and safely, particularly from folks who specialize in it, and particularly venous sinus stenosis is able to be very readily and safely treated now. Let's go back and talk about some definitions. Tinnitus overall is the appreciation of sound without an external source. And pulsatile tinnitus is a subset of tinnitus that has a rhythmic component to it. So as long as there's someone's experiencing a rhythmic kind of sound that nobody else in the room can hear, well, that's pulsatile tinnitus. And it's fairly common. It accounts for 10% overall of the tinnitus patient population. And if you were to estimate the overall US patient population right now, we would guess that maybe 3 to 5 million Americans are currently suffering from pulsatile tinnitus. So if you're one of those folks, you're not alone. There's millions of us out there that also experience the same type of symptom. And unlike continuous tone tinnitus, which many people have for myriad reasons, most commonly related to hearing loss, pulsatile tinnitus can have a very dangerous underlying blood vessel cause for the symptoms. And so this is a recording, hopefully that's coming through okay, that I took using a fancy stethoscope that we have in our lab, placed on a patient's head, actually one of these patients with a dural arteriovenous fistula, and this is what patients with pulsatile tinnitus often hear. And it can be quite distracting, debilitating, and as people get anxious or worried about this sound, it gets louder, it gets faster, because the amount of blood flow going through this abnormality then goes up. So obviously, this can drive people crazy. And pulsatile tinnitus is serious, in addition to just being a sort of annoying sound. When we looked at our experience in bringing patients with pulsatile tinnitus into an angio suite, where we do invasive catheter-based imaging to look at what the underlying cause is, we found that 75% of our patients had an abnormal blood vessel causing their sound, or abnormal flow in a blood vessel causing their sound. So 75% of these patients have a vascular cause for their symptoms. And overall, nearly a third of them have a dangerous vascular cause. And by that, I mean a cause that could lead to a stroke or bleeding in the brain, something that could be permanently disabling or even life-threatening for folks. So pulsatile tinnitus is serious because the underlying causes can be potentially life-threatening. It's also serious because many of our patients, we've learned, have an associated comorbid psychiatric kind of state where they have serious depression or anxiety. And what we found is that 46% of these patients, this is a national survey we did of pulsatile tinnitus patients that was, for the statisticians, powered to cover at least the entire Earth's population of pulsatile tinnitus. And we found that 46% of patients have debilitating depression, 37% have debilitating anxiety. And our data found that 15% of patients have thought about committing suicide, and other people have published data that suggests there's a 25% suicidal ideation rate. So a quarter of the patients who have pulsatile tinnitus, maybe an eighth, have this ideation where they're thinking about ending their life. So this is seriously impactful for a lot of people. And to put this in perspective, these numbers are higher than what we see for other chronic health conditions like heart disease or even a stroke directly. This seems to be more directly impactful. And I found that to be very curious. I didn't really understand why a sound could be so impactful to people. So what we did is we did a research study on this, and in our group, we routinely get a specialized sequence, an MRI, that allows us to look at the thickness of the cortex of the brain, which is the part that the cells live in, that do the thinking, if you will, as well as the white matter, the connecting cells between all the different cells in the brain. And what we found in looking at 140 patients in their seventh decade of life, who had pulsatile tinnitus compared to normals, age-matched controls, we found that the thickness of the brain in certain areas was getting kind of beat up. And if we look at what these areas are responsible for, certainly this is auditory processing, and that makes sense, right? If there's this constant noise happening, the areas of the brain that are responsible for auditory processing are getting bombarded. But if we look at these other areas, these taken as a whole are part of a set of circuitry called the limbic system, which is responsible. The limbic system is really responsible for the body's responses to emotional stressors, right? So perhaps it's this impact on the limbic system that is the underlying physical cause for why patients with pulsatile tinnitus seem to have higher levels of depression, anxiety, and suicidal ideation associated with their condition than really any other medical condition that I'm aware of. So pulsatile tinnitus is serious because it can be caused by a dangerous underlying vascular problem, but also because it has this sort of serious associated debilitating depression, anxiety, and suicidal ideation. The good news is many of those associated depression and anxiety situations are also treated when the underlying cause of pulsatile tinnitus is treated. So the sound goes away, and then patients can get better and get their lives back. So,
Sorry.
yeah.
Can you go back? That's new information to me. Where did you publish that and when? This is fascinating.
Within the last year or two, and it's in, oh, honestly, I can't remember, Pierre. Honestly, I'll send you a text with it. I can't remember. But this was 135 patients in the seventh decade of life compared to age-matched controls. And the reason we use the seventh decade of life is because that's what we had the most age-matched controls of. Not just because we were, only interested in folks in their 60s. It's just that's where we had the most controls. And these were consecutive patients that were in that particular age group.
Did you compare patients pulsatile tinnitus and patients with regular tinnitus?
No.
With continuous tinnitus?
No. This is just our pulsatile tinnitus patient population compared to age-matched controls. Continuous tone tinnitus has found similar associations, particularly in the auditory processing, Heschel's gyrus types of regions. But I think this impact in the limbic system is more recently being understood. I think this is also seen maybe in patients with chronic pain types of syndromes, where this types of regions of the brain are being beat up.
Fascinating. Thank you.
Yeah. All right. So maybe I've convinced you that pulsatile tinnitus is serious. So now all we have to do is diagnose it, right? So it's pretty straightforward. All you have to do is search Google, and then you come up with these types of algorithms where there's these crazy lists that are incredibly long and complex. This list comes from the neuroradiology literature. There's different lists for the ENT surgeons, the head and neck surgeons, family practice. Everybody has their own different lists, which our team particularly I found to be too complicated. I am not a very complex man. I try and keep things as simple as I can. So our team really has a differential diagnosis that has three things: tumors and structural problems that can cause pulsatile tinnitus, then vascular abnormalities that can cause pulsatile tinnitus, and then what we're calling neurogenic pulsatile tinnitus, which is basically that the circuitry of hearing is firing and telling the brain there's sound, but no physical sound is being generated. So three big categories. And the reason we use these categories is because it then determines which physician is going to take care of the patient, right? So this is our team our clinical team at the Pulsatile Tinnitus Clinic. And we have our ENT surgeons, our neurologists who take care of our patients who have tumors as causes, our neurointerventionalists who take care of the vascular causes. That's a little shout out to my French buddy there. Dr. Goban. All right. And then neurologists and our nurse practitioner, Allison, who take care of our patients with neurogenic tinnitus. So breaking down in each of these categories, really, I like to focus on vascular causes. That's what I do for a living. And really, we're talking about blood flow related problems that can be involving the arteries, which are the high blood pressure blood vessels that go from the heart to the brain. Abnormalities in the arteries are the ones that are most likely to cause a stroke or can lead to bleeding in the brain. So these are usually dangerous causes of pulsatile tinnitus. Causes in the veins that may or may not be dangerous. Many of them are actually not likely to cause bleeding in the brain or a stroke, but can still be disabling for patients for all the reasons we talked about a few slides ago. And then combinations of a problem between arteries and veins would be like the dural arteriovenous fistula case that I showed earlier, where we saw that fast blood flow coming from the arteries and into the veins. So vascular causes, blood flow related problems, they can be in the arteries, the veins, or a combination. Structural causes, well, we're really talking about different types of tumors, metabolic bone diseases, bleeding in the brain, or stroke, depending on where it occurs, can cause pulsatile tinnitus. And really, any of these abnormalities can happen in the brain, the temporal bone regions around the ear, down in the skull base, or in the neck. For neurogenic pulsatile tinnitus, we're talking about the circuitry of the hearing, firing, and telling the brain that there's sound, but nothing's present. There's lots of different underlying causes, including toxic exposures. I found this to be interesting, various types of migraines where the patients don't actually necessarily have a headache, but it's this malfiring neuron symptom from migraine that can cause this. Different types of infections, inflammation, maybe this thing called myoclonus, which is like muscles twitching in the palate or in the middle ear that creates this sort of suction cuppy sound. That one's actually not in sync with the heartbeat, unlike the blood vessel causes. So blood flow causes are always in sync with the pulse. So you can feel your pulse and see if it lines up. Myoclonus, it's not, it's more random. So these are the different neurogenic types of causes. And at our shop at UCSF, to differentiate among these big three categories of tumors and structural problems, blood flow problems, and neurogenic, which often we don't see much on imaging, we rely on MRI, and this is our specific protocol. We've published it extensively. And I'm not going to go into it in detail other than to say that these sequences are set up for that first category, tumors and structural etiologies of pulsatile tinnitus in the head, neck, and temporal bone. These are looking at blood vessels, particularly the arteries that can cause pulsatile tinnitus. These ones look at other blood vessels, the veins that can cause pulsatile tinnitus. And so really this algorithm is designed to look at the vascular and tumoral and metabolic abnormalities that can cause pulsatile tinnitus and infections and stuff. So all of our patients that come into our clinic, they all get this. This is like non-negotiable. We want to have it for everybody because it's really high quality stuff and it gives us a great series of images that can identify potential causes of pulsatile tinnitus, and it makes our diagnosis much more accurate. And then once we have the MRI, this is our algorithm. It's a bit complicated, but really there's only a few key categories. This one here on the left, if we think there's something dangerous based on that MRI that we saw, then almost every patient ends up in an angio suite where we do a catheter-based angiogram to study the abnormality that we think might be dangerous and potentially be able to treat it from inside of the blood vessels. Patients where the imaging is okay, but our physical exam suggests that there might be something dangerous that's causing their symptoms, well, they also end up in the angio suite, same place where we can study the blood vessels and potentially treat the abnormality from inside of the blood vessels. So any imaging or clinical suspicion for something dangerous, they all end up with an angiogram. On the other side, if somebody has like a very safe cause, it doesn't cause a stroke or it won't cause bleeding in the brain, and the patient's okay with it, like they're okay with this sound, it's not driving them crazy, and we know it's not, their brain's not going to explode, we know it's this thing, it's not dangerous. Well, those patients don't end up in an angio suite. We tell them this is what it is, and we don't necessarily have to do anything at all further because we know it's not dangerous and they're doing okay. But there's this other group of patients. Yeah.
So, well, you are talking about conservative management. What is conservative management? Is there any non-surgical, non-endovascular way to decrease the symptoms of pulsatile tinnitus?
Well, we try, particularly for neurogenic tinnitus, try and calm down the nerves. And there's several medications that our team uses. They're not always effective, and they're not always the same for everybody. And we end up trying to, pick the lock, the combination lock, try a little bit of this, a little bit of Topamax, a little bit of this, and a little bit of gabapentin. And all these medications do have side effects. So honestly, if the patients are not debilitated by their symptoms, we don't do anything, because oftentimes the different medications we try are not always effective, and many of them have side effects. If it is, rarely some of these medications can work, but really the most effective certain way to treat this is with an endovascular or surgical type of procedure.
So there is no helmet, with a noise suppressor, something that could help patients go to sleep, because I've known some patients who said, my pulsatile tinnitus doesn't bother me when I'm awake, but it's when I'm in my bed at night, and then I cannot go to sleep. So that could be the moment where they put the helmet, or is it?
Yeah, I haven't seen anything that'll cancel it out. People do try masking it with other sounds, fans and ocean noises. I like oceans, but my wife doesn't. So the difficulty with those is it usually affects the other person trying to sleep in the room. And some people are able to use them and find some benefit, but I haven't found it to be particularly effective. Most people who are traveling are coming to the UCSF Pulsatile Tinnitus Clinic, and we see people from around the world. They've already gone through all that stuff. So us telling them to use white noise would be like rude to many of these patients. They find it to be kind of insulting because it doesn't usually work.
They have tried it, and
And they've often tried it at all. Yeah.
And do you have patients who have pulsatile tinnitus? They are very anxious about it, and then you tell them, "Oh, it's no risk venous sinus stenosis, or no risk for any other medical reason," and then they find it tolerable because you just reassured them.
Yes. Definitely. And in fact, when I diagnose a venous sinus stenosis, I always tell them I can fix this, and we can try different medicines like Diamox to lower the intracranial pressure, which always makes people sick and doesn't usually work. But I offer a venous stent, but I delay it. Like, we're going to talk about it, and then you're going to have a little bit of time and think about this, and then we'll talk about it again. Because I like people to have a chance to digest what I tell them. I'm not sure if you caught this. I know you know me well, but I speak kind of fast. And so it's nice to give people like a minute to catch up after I say it. So I usually give them some time to think about it. But before we do that, when we don't think it's a dangerous cause and they do want to go on with treatment, we try and prove that that thing is the cause of their symptoms. So those patients end up in an angio suite, making sure there's nothing else to cause their pulsatile tinnitus, so another angiogram. And then we try and do a balloon occlusion test or something similar, where we stop the blood flow in the abnormality we think is the cause, and see if the patients tell us their sound is gone, right? That's very reassuring. Or if we're not sure if it's the cause, particularly if, especially if we're not sure, we try and prove that's the cause before we do some sort of permanent implant of hardware in somebody's blood vessels in their brain to make sure that they're very likely to, have a good result from the treatment.
So while you are talking about the balloon test occlusion, let's talk about jugular compression. And there is a question from the audience. Can you have pulsatile tinnitus due to venous sinus stenosis that does not stop when you apply compression to the neck?
Yes, definitely. So the sigmoid sinus is, let me see. I got a picture here. Skip. We can skip ahead. Let's go to, we can come back to this stuff. There's a picture here of a transverse sinus. Okay, so venous sinus stenosis is the most common cause of pulsable tinnitus. The usual location here is in the lateral sinuses, the lateral aspect of the transverse sinus into the sigmoid sinus. And the sigmoid sinus comes down and often drains into the jugular vein, but not always. Especially if the jugular vein is not patent, if it's narrowed for whatever reason. It turns out, I think a lot of people have narrow jugular veins. It's not necessarily causing symptoms. I don't want to get into the jugular vein discussion right now, but there are other veins that come out of the skull base in this region. So when these are closed, there's accessory veins that can take the blood flow away from the sigmoid sinus, particularly along the back of the neck. So like the deep cervical veins, the ascending cervical vein, and into the epidural venous plexus through the condylar venous system. So there's other ways for all this blood flow to get out. So it doesn't necessarily mean that the absence, it doesn't mean, if the sound doesn't go away with jugular compression, it doesn't mean that there's not a transverse sinus stenosis. On the other hand, if the sound does go away with jugular compression, it is most likely that the patient has a venous cause of pulsable tinnitus in that outflow pathway that is being stopped. The most common of those is venous sinus stenosis.
So false negative are they frequent?
Yeah, I think they're fairly frequent. I don't let it get in the way. If there's
However,
obvious transverse sinus stenosis and everything else sounds venous, the pitch of it, which is usually a lower pitched pulse synchronous, kind of a humming sound, like a sound, lower, deeper and characteristic than the one I initially played, which is from a dural arteriovenous fistula. The arteries, they sound higher, like a psh, psh. Those types of sounds. So it's more venous, worse with lying down, better with standing up. It pauses with the Valsalva type of maneuver, which slows the blood flow through the veins because it closes the valves in the jugular valve. These other things line up, and there's a transverse sinus stenosis. I don't mind if the sound doesn't go away with jugular compression.
so that's why you believe strongly into the balloon test occlusion.
Right. In that situation, I would do a balloon occlusion test and measure pressure gradients, or even like temporarily, you can dilate the transverse stenosis with a balloon. The patients will tell you their sound's gone. It doesn't work permanently. It's never permanent. But there's other ways we can try and prove that that's the thing. So whenever I'm not 100% sure, that's the way I go.
Okay.
Thanks, Bear. Let's see, 20 minutes. We can talk a little bit about the physical exam. And then I'll go into transverse sinus stenosis in a little detail and some science that we have on transverse sinus stenosis and how it causes pulsable tinnitus. Sound good? Sounds good. All right, so for the physicians who are maybe watching this and they're seeing patients with pulsable tinnitus, some historical pearls, some things that patients talk about, and even for the patients who might be watching this, some things that would make this more likely to be more dangerous or not. Let's talk about that. So pulse synchronous versus not pulse synchronous. So if the sound is not in sync with the heartbeat, if it's not regular and rhythmic, that goes along with the pulse that you can feel in the wrist, it's probably not vascular. And then the pitch that we talked about, the frequency, the frequency characteristics of the sound, the pitch of the sound. The lower pitch stuff that I just talked about, that's the venous stuff, that humming kind of sound, because it comes through a wider blood vessel. The higher pitch stuff, that comes from arteries or dural arteriovenous fistulas. But if it's a very high-pitched tone, and you take these tone generators on YouTube or wherever you like, and it's 10 kilohertz or 6 kilohertz, like incredibly high-pitched squealing noises that even some people can't even hear, they're so high-pitched, that's not vascular. Because blood flow, in my opinion, for pulsable tinnitus, it's a physical sound being generated by the viscous blood moving through an abnormality that generates the sound. So if it's a very high pitch, you can never move viscous blood fast enough through a whistle, for example, which we know makes sound, to get a very high pitched sound, right? And then we talked about this oh, sorry, not this part, but if patients also have hearing loss on the same side of their symptoms, it's often that we find a tumor in these patients, and it can be very subtle to find the tumor. The most difficult of which is within the cochlea itself, the intracochlear schwannoma. And then if patients have hearing loss on the opposite side of where they're appreciating symptoms, well, then the lateral, where the thing is that causes sound could be anywhere because patients are only hearing things. You know, if you're only hearing things out of the right ear, everybody thinks that the sound is just coming from the right because that's all they have to tell them where the sound is coming from. So if there's hearing loss contralateral to where people are localizing their symptoms, the sound can be generated anywhere. And so the laterality of the symptoms should not define the laterality of where we evaluate. And then for those who are seeing these patients, we can close the blood vessels manually. So as Pierre talked about, we can do jugular compression, which is just sort of mild pressure with the whole hand across the neck. So this is jugular compression. It doesn't close any arteries when we do that. To do arterial compression, you kind of have to be trained to do it for the carotid artery. But the arterial compression we can do is the occipital arteries. So there's a little notch in the skull back behind the ears. That's the groove basically for the occipital artery, and you can feel your pulse there. And if you press on that and the sound goes away, it's most likely that there's a dural arteriovenous fistula, a more dangerous cause. And then you should seek out somebody like myself to get this treated because those can be dangerous. And then head turning maneuvers, this also works very similarly to jugular compression. So whenever really anybody turns their head and puts their chin like on their shoulder, it closes the jugular vein on that same side. So I turn my head to the right jugular vein closes. That usually stops the blood flow in the right venous system and will make venous causes on the right quieter. We also do cranial auscultation. So we listen to the patient's head. This other one allows both the patient and the physician to listen at the same time. It can be kind of a fun party trick, I don't know. But we listen behind the ears, over the transtemporal windows, frontal and up to the vertex and across and down across where the superior sagittal sinus goes to the occiput. We do transorbital windows for the carotid cavernous types of fistulas and certain types of arterial stenoses inside of the head you can hear. And then, of course, in the neck, listening for bruits from carotids. And over the heart, aortic stenosis, particularly for older ladies, can cause pulsatile tinnitus. I think it's on the right. And then for the physicians, if you hear a bruit, or for the patients, if somebody can record it with an iPhone, it's most likely that that's a more dangerous cause of pulsatile tinnitus. And so those patients should seek help and consider doing a diagnostic cerebral angiogram to ensure there's not a dangerous cause. All right, so
that's very interesting, and I want to insist on that. When the physician hears the bruit, it is never or rarely due to a pure venous sinus stenosis.
That's correct. Unless you're like very skilled at evaluating for it. A venous stenosis has a very characteristic kind of low pitch humming kind of sound. But if you put it over the bell or the diaphragm, actually I think the diaphragm's better, contrary to what's been taught in the past. The diaphragm's better than the bell. If you hear something, that's probably a dural fistula, like almost always. Arterial causes and dural fistulas, they have such high velocity blood flow to them that if you're hearing it with a stethoscope, unless you're like very well trained neuroradiologist or whatever, a neurointerventionalist who treats a bunch of patients with pulsatile tinnitus and you listen to heads all the time, you're probably only going to detect a real bruit, which is from an artery or a dural fistula.
So I have a related question from the audience. If you see white matter hyperintensity, could it be a pure venous sinus stenosis, or should we suspect an arterial cause?
White matter abnormalities can be caused by many different things. I don't think I'd get hung up on that. And often radiologists report it, and often neurologists dismiss it because there's just myriad causes, and really a neurologist needs to sort out the white matter stuff. Really, if there's, I would see that as completely independent. unless there's evidence of prior bleeding in the brain or specific areas of the brain that are atrophic, like getting smaller because there's too much venous pressure hitting them, or there's engorged veins throughout the brain. These are the kinds of things that are really red flag symptoms on the MRI that there's an underlying dangerous vascular cause. All right, so 20-year-old patient here, she has right-sided pulsatile tinnitus. It gets better with right neck compression. So that closes the jugular vein, stops the sound on the right. That's anything along the right venous outflow pathway can be causing it. Better with right head turn. Again, that closes the right jugular vein. No bruit on exam. So interestingly, her sound gets worse with left neck compression. So the venous sinuses in the head connect between the right and the left. So by stopping outflow out the left, it pushes more out the right. So this is venous pulsatile tinnitus. And if you're a betting person, you would just bet that there's transverse sinus stenosis. So that's the case. This is the vein on the right. And this is the normal caliber. You can see in this segment it narrows. This patient also has extra pressure in her cerebral spinal fluid, which normally drains into the dural venous sinuses. And so this is dural venous sinus stenosis that we had mentioned earlier. This is the #1 cause of pulsatile tinnitus. It's probably 40% of the time this is the cause. So it's just less than half of overall patients who have pulsatile tinnitus. So if you're not seeing pulsatile tinnitus all the time, but you're maybe reading their MRI scans, if you're not calling dural venous sinus stenosis about half the time, you're probably missing it. This is the most common cause. It's about 40%. And I like to call this symptomatic venous sinus stenosis, which basically is an anatomical thing, this narrowing in the vein, is what's causing patient symptoms, which could be pulsatile tinnitus, headaches, diminished executive functioning, or what people like to call brain fog. Papilledema, if patients have papilledema, then they get this name, idiopathic intracranial hypertension, but it's not really idiopathic. It's just another version of symptomatic venous sinus stenosis. Papilledema is caused by the intracranial pressure being elevated, then that intracranial pressure being transmitted along the optic nerves, and it starts to press on the back of the globes, and that can lead to vision loss. So symptomatic venous sinus stenosis is really this anatomical abnormality that can cause any of these different symptoms. But what it doesn't cause, as long as the vision's okay, and the vision stays okay, and there's not papilledema, is it doesn't cause a stroke. It doesn't cause bleeding in the brain. So I'm going to move forward to some other causes. This patient had a stenosis in the dural venous sinuses here. So this is the images from an angiogram, and it's interesting. It's kind of hard to tell that the vein is narrowed, but really it's a ribboning out of the vein, and it kind of loses its density there, as opposed to looking like a notch stenosis all the time. But on the lateral, maybe it's easier to see that the vein is narrowed in this segment. And so we can treat these patients with a stent, which is a permanent implant, into the dural venous sinuses. Here it is. And it cures the stenosis. It cures almost always the papilledema that patients have. This is very serious papilledema the patient had. 2 weeks later, it's mostly resolved. There's a lot of, for the neuro-ophthalmologist watching, there is optic atrophy here. She had it going in. But anyway, at 2 weeks, we start to see the improvement, but sometimes it can take 6 weeks or even months for it to fully resolve. It takes some time. So even if you put in a stent, if it's not better right away, the papilledema, it's okay. The pressure goes to normal immediately, and it sometimes takes some time for this stuff to resolve. So just we can relax. So symptomatic venous sinus stenosis.
I have a question here from the audience about venous sinus stenting in IIH. It's an IIH patient who had a stent placed. Papilledema went away, and she's globally fine, except that she still has a pulsatile tinnitus that is there. It's less intense than before stenting, but it's still present. Should be worried about it. That's the question.
So That's a challenging one to answer. If the sound went completely away and then it came back, that should be reevaluated because very, very rarely, I've seen it once, I saw it published, I didn't believe it when I saw it published, but certain stents can exert too much pressure on the venous sinuses. I don't really know how this happens, but a new dural arteriovenous fistula can form in an area of a prior venous sinus stenting. I've only seen it once out of hundreds of patients that I've treated, but it's possible. So I would get reevaluated if the sound went away and then came back. If the sound is much, much better, but it's the same sound, it's just much quieter, and you had a full evaluation with a full diagnostic cerebral angiogram, including over the neck, because there's sneaky little fistulas that can hang out down here in the neck, then I wouldn't be worried about it. It's the same thing, it's just a little bit better. Sometimes there's multiple causes in the same venous outflow pathway, and so the dominant cause could be the venous sinus stenosis. There could be something else that's also causing a more minor amount of sound, but I wouldn't be concerned about it as long as it's the same sound, just better, and there was a full evaluation going in. Okay, so we talked about venous sinus stenosis. For the imagers who might be watching, this is what it looks like. This is a post-contrast coronal view of a SPGR type of a sequence. You cannot use a black blood sequence to see this. You need the blood to be white. You want to see the contrast in the veins. So these are the normal transverse sinuses. And then as we go back another slice, we don't see the normal transverse sinuses. We see these big arachnoid granulations, and the vein is very narrowed. We don't really see the normal vein there. And then as we keep going back again, we see the vein come back. So this area where there's no vein that we see, that is the stenosis. Even though it is an arachnoid granulation that's causing it, that is the thing. That's what's causing the stenosis. That's what's causing these patients' symptoms. So vein, no vein, and then vein again, that's venous sinus stenosis. It's kind of like looking at a fracture. You see bone, and then there's a segment where there's no bone, and then the bone again. The no bone segment is the fracture. Just like that, the no vein segment is the stenosis on the MRI. On an MRV, again, this is phase contrast, but we can see this section where there's no vein. That's the thing. That's the stenosis. So venous sinus stenting, it's 95% effective in curing pulsatile tinnitus in patients who have been diagnosed with IIH and PT in general. As long as that vein is the cause, we remove that stenosis is the cause. We remove the stenosis, and the sound is gone. It basically works, at least 95% of the time. So I was curious about this. How is sound physically generated? I'm an engineer by training and did engineering before medicine. And I really wanted to know, why is this stenosis causing pulsatile tinnitus? So what we did is we took a bunch of patients in whom we thought the venous stenosis was causing their sound. It got better with jugular compression. We saw the stenosis on the MRI. And we brought them to our fancy research magnet, which we have at UCSF. It's nice to have this great institution that supports research. And we had them rate their pulsatile tinnitus on a scale of 1 to 10. And then we put in the MRI scanner, we looked at the vein and saw if it was narrowed or not. And we did this fancy blood flow imaging that I showed earlier. And then while they were in the magnet, we did an MRI guided lumbar puncture and drove the CSF pressure, the pressure in the fluid, really low. And then we asked our patients on a scale of 1 to 10, how loud is your sound? And almost always the sound goes away, as long as that stenosis is not stuck, not fixed. And in those where the sound went away, we put them back in the MRI scanner. We repeated the imaging to look at the vein and looked at the differences in the blood flow before and after the lumbar puncture. So when they were very symptomatic and when they were not. And what we found, again, red is fast blood flow, blue is slow blood flow. So before the lumbar puncture, when they had symptoms, there's this jet of high velocity blood flow that comes from the stenosis and bangs on the bone that basically is tuned to transmit sound to the cochlea. The cochlea, of course, is the sound transducer. It takes that vibration and turns it into sound for the brain. And after lumbar puncture, that flow jet was gone. So this is a graph. Red is while the patients are symptomatic. Blue is while they're not. The y-axis is the speed of that blood flow. And what we see is after the lumbar puncture, the speed of the blood flow slows down in the same locations. And when we look at the vein, what we see is that the stenosis actually can open up in these patients. So we think it's high velocity blood flow caused by this stenosis that patients are hearing. But does that flow make sound? So what we did is we took the veins of these patients and we segmented them out, separated them from the MRI scanner, and then we printed out their veins in wax, which you see here in blue. And we took that wax model and we put it in a plastic fixture and melted the wax out so that we're left with a hollow tube of what these veins look like. And because we measured the blood flow in these veins, we could then program a computer to push water that is doped with glycerol to make it the same viscosity as blood through these veins and recreate maybe sound. So this is the stenosis in the pre-lumbar puncture, and this is that same patient after the lumbar puncture. We see the stenosis is gone. And so we put these and hook these up to our flow circuit, and you can see we just have a stethoscope here, and it's right over top of where the stenosis was. And this is what venous stenosis sounds like. And we played this for our patient, and she was crying. It was a very moving moment. Her family was like, mom's not crazy. This is the thing. It's really there. It was very exciting. And then post-lumbar puncture. Post-lumbar puncture is this one. This rumbly kind of sound is normally what veins make. So no pulsatile tinnitus. So we really think we've proved that there's physical sound being generated from the venous sinus stenosis caused by this high velocity flow jet. That after the stenosis is gone, the flow jet is gone, there is no sound. So, this is what we've done now to help prove that pulsatile tinnitus is real and really is physically caused by the stenosis. This technique is also helpful to determine what anomaly is physically causing sound. So if you're an astute neuroradiologist like Professor Gobin, you'll notice that there's also a diverticulum sticking off of the sigmoid sinus, which is a potential cause of pulsatile tinnitus. We can debate that. But in the post-lumbar puncture model, when the sound is gone, that diverticulum is still there. So I would argue that the diverticulum doesn't actually make the sound in this situation. It's the stenosis making the sound. Maybe the diverticulum transmits that sound, but no sound, diverticulum still there. So 3D printed models can help us to understand what's physically causing pulsatile tinnitus and prove an anatomical cause and prove which one does or does not cause pulsatile tinnitus. So with that, we're at 12 minutes. So far to review, we've talked about pulsatile tinnitus and it's serious. There can be underlying dangerous vascular causes for it, those that can lead to stroke or bleeding in the brain. And even if it's not a dangerous cause, many of these patients can be severely debilitated because there's this very high rates of comorbid depression and anxiety. And we think there's probably a physical structural reason for that because we're seeing the areas of the limbic system in the brain getting beat up. The most common cause of pulsatile tinnitus is venous sinus stenosis, and this can be treated with a venous sinus stent. Do you want to go into questions now, Pierre, or I have some other cases if you're interested of the different causes?
So we have a few questions that are not directly related to pulsatile tinnitus, but to venous sinus stenosis and IIH in general. So one question is stenting venous sinus stenosis if a patient has a headache. That's a tricky question because it's not really, we go into IIH now. So do you want to talk about that, Matt? Headache and venous sinus stenosis?
I think it's a challenge. If the headache is caused by the elevated intracranial pressure, then making the intracranial pressure normal, which is what venous sinus stenting does, can treat the headaches. But many patients with IIH also have a separate headache disorder. And confounding it is sometimes those headaches even get better after a lumbar puncture, but it's still not directly due to the elevated intracranial pressure. And the way I know that is because they get treated with a stent and the pressure is normal, but they still have the headache. And some of those patients even go on further to have a shunt implanted, which is a tube that goes from the cerebral spinal fluid and into the abdomen. And they drive that pressure down even farther, and they still have the headache. So it's not a, even though it looks like it's definitely a pressure-related headache, it's very hard to tease out if there's a separate headache disorder that's unrelated to the pressure, because sometimes we make the pressure normal and the headache's still there. The other problem, I think, as we're learning from low pressure patients as well, is the longer patients have a cerebral spinal fluid pressure disorder, the more likely they are to have a chronic headache condition after the fluid pressure is normalized. So patients who've had this for decades, I tell them, I don't know how likely it is that their headaches are going to get better just because, the pressure's been abnormal for a very long time. So it's a challenge. But the literature does suggest that 2/3 of the time, venous sinus stenting can help the headaches.
So I have other questions. I find that when I lie down, the whooshing pulsatile tinnitus gets worse. Is this due to my hearing my own pulse, or is it due to my IIH?
Well, it's hard to know for sure. I mean, we would have to do a full evaluation to determine what the underlying cause is. But I would say that it's most common that patients with venous causes of pulsatile tinnitus, it gets worse when they lie down. You might say that maybe the outside sounds are gone because you're sleeping and it's quiet in your room. And maybe it's a lack of masking, of the outside noises that's making it easier to appreciate. So one way to tease that out is to see if the sound actually gets quieter when you stand up in that same quiet room. Let's say you have to use the restroom or something like that, right? So if it gets quieter when you stand up in that same room, well, then that is actually a positionally dependent symptom. So it's worse when lying down and better when standing up in the same quiet room. That's most common in venous causes of pulsatile tinnitus, but it doesn't necessarily ensure that it is definitely a venous cause of pulsatile tinnitus.
Okay. So another question. I have a former history of IIH, which was relieved with a left venous sinus stent. I still have pulsatile tinnitus, I suppose on the right, due to a sigmoid sinus diverticulum on the right. And so the question is, do you think that was caused by IIH?
So we looked at that. Venous sinus stenosis does, most sigmoid sinus diverticular are caused by venous sinus stenosis. That same jet that I showed of high velocity blood flow hits the sigmoid sinus plate, the sigmoid plate is what's called, in that location, and kind of remodels that bone because the long axis of the diverticulum is coincides with that flow jet, the center axis of that flow jet. So it's like a pressure washing phenomenon that occurs at the bone that creates the sigmoid diverticulum. Almost always there is a stenosis associated with that diverticulum. If the diverticulum is on the opposite side of the stent, there's probably a stenosis still there as well, that may be causing the sound. I think most of the time, the diverticulum allows sound to transmit into the mastoid air cells, which are the part of the bone that's really tuned to transmit vibration into the cochlea, which is the sound transducer of the head. So we can treat pulsatile tinnitus by treating that diverticulum. What it does is it sort of blocks the transmission of that vibration into the mastoid air cells.
So I have another question is about evaluating the degree of stenosis. And the question is
About eliminating the degree, did you say?
the evaluation of a degree of stenosis, because usually we under, I mean, so I'm going to read
Yeah, go ahead.
and you can. Someone has a 30 to 35% stenosis and has pulsatile tinnitus. Will you consider stenting the vein?
I would. I don't think that, I think it's very challenging. Okay, so a couple things. One, it's very challenging to measure the degree of a stenosis in a dural venous sinus because the transverse sinus is a triangle in cross section. It's not a circle. And so people will measure like, let's say it's 4 millimeters across in the circle, and then they measure another 2 millimeters on the other side of that in the axial plane, but it's a triangle with a circle shoved in the middle of it. And so that's not actually like 2/3 stenosis. That's more like 90% stenosis because it takes away almost the entirety of that triangle other than that little corner. So I think that's a bit of a challenge to physically measure it that way. Also, it doesn't matter, right? Like if that stenosis is what's causing the sound, what do I care if it's 20% or 90% or 180%? It doesn't matter to me. That stenosis is causing the sound. I make that stenosis go away and the sound's gone. You can tell me whatever percentage you wanted, and I don't really care if the sound is gone and my patient's happy, right? Like that's all I really truly care about. For IIH, it's a pressure problem. It's not a degree. It's not like measured degree of stenosis problem. So that one, it's a pressure measurement that we measure in the dural venous sinus. If it's elevated in the dural venous sinus and goes to normal downstream from the stenosis, I don't care what the measured amount is. It's an irrelevant measurement. That the only measurement that matters in IIH, pseudotumor, that's a pressure measurement. For pulsatile tinnitus, the only thing that matters to me is the sound is coming from that thing, and if I make it go away, the patient is better.
Okay, so you answered already another question from the audience is that is there a gradient, a pressure gradient across the stenosis at which you stent or not? So your answer is that you will stent according to the symptoms and not according to a pressure gradient. But do you prefer when there is a pressure gradient? Isn't it reassuring if there is a pressure gradient?
Yeah, it's reassuring, but it won't stop me from treating a patient if I think that stenosis is causing their sound. If the contralateral, so unilateral venous sinus stenosis can cause pulsatile tinnitus. So there's a stenosis on the right, the patient has right-sided pulsatile tinnitus. The left side can be wide open, but the patient still has symptoms from that right-sided narrowing. If the left side is wide open, there will be no pressure gradient across that stenosis because the pressure is being decompressed out the left side. So I like when there's a pressure gradient, but it doesn't stop me from treating the patient. If I can prove that that stenosis is the most likely the patient's cause of their symptoms and they're debilitated by their symptoms, I'm willing to treat them.
So one physician from the audience has a problem is that her patients refuse the contrast-enhanced MRI. But she suffers from the pulsatile tinnitus and she wants to be treated. So what would be your alternative examination? What would you do? What would you offer? I don't know why a patient will refuse the contrast enhanced MRI and accept another examination, but suppose.
It happens. I mean, I see it all the time, but I mean, we do the best we can still with MRI. I still would rely on MRI as the first choice. The challenge of not using contrast is tumors will be missed. Strange infections will be missed. We won't make that diagnosis. For example, this is a patient with a normal right-sided cochlea on this MRI. On this side, there's this little speck of enhancement. This is the cause of her pulsatile tinnitus. That's a tumor sitting in this cochlea that would never, ever be able to be identified with any other method other than this MRI. And if we go down the road of evaluating the blood vessels, we're never going to find it. If we try and treat a stenosis, it's never going to work because this is the thing. And the only way to see it is on a contrast-enhanced MRI. So that's why our team really tries to push to make sure we get this because we don't want to miss an obvious tumor that's causing a patient's symptoms when it's sitting there and able to be found. Gadolinium, I don't think is dangerous to patients. It does, we know, accumulate in the dentate nucleus of the cerebellum and probably other places. And we're finding, this made big news at some point in time in radiology, but it fell out of the news because it turns out it doesn't seem to matter long term. So I would still push for the MRI. You can get a CT temporal bone, it just won't be as good. You can get a CTA and time into the venous phase, it just won't be as good.
So it's already 3 o'clock, so we have to stop. So the final question is, what factors are most important in proving a stenosis is causing the patient pulsatile tinnitus? So, I mean, it's really everything you discussed.
Stenosis present on imaging, patient symptoms get better by stopping blood flow across the stenosis. I mean, I'd say that's how I would wrap it up.
Thank you, Dr. Amans, so much for your work with your team and for all that you do in pushing the needle forward for pulsatile tinnitus. Thank you for your time today. It's been truly an honor. We're very grateful to have you today. We would love to share your information with the community. If anyone wants to reach out to you or if anyone wants to see you as a patient, if that is okay with you, we would greatly appreciate it.
It's best to reach out straight to the clinic and go through that method. I get hundreds and hundreds of emails per day, and I'm usually scrubbed into an angio suite and can never actually answer them all. So the best way to make sure that your questions are answered or you get a chance to see us in the clinic is to work directly with the clinic.
Thank you. Thank you very much for your time.
I will just add something, is that many participants did not get the right QR code, so joined us later in your speech, I mean, during the conference. And this entire talk is going to be available on YouTube.
Well, thank you all for the opportunity to be here today. I really appreciate it. Nice to see you, Pierre.
Thank you, Matthew. It was a pleasure.